It's my pleasure to introduce the first ever Medtech Flyers winners whose projects were selected for funding of up to $25,000 to help prototype and develop new medical device concepts from teams in urology, pediatrics, and general surgery. This funding is to help give lift to ideas and concepts that need early support for development and that have a clear pathway for impacting patient care and the clinical tool set. These teams will engage closely with UH Ventures over the next year as we work to plan for and support project milestones for their technologies along the earliest stages of commercialization. Now, for those wondering if there will be more opportunities in the future to participate or additional funding, definitely we'll be opening up another round of submissions for the spring of 2022. So please make sure to watch out for that notice coming out over the next couple months. And also for those wondering how to participate, these three projects are really representative of a great first batch to see what sorts of med device ideas have a good chance of getting funded. All right, so let's get into our Medtech Flyers winning projects. First up, we have Colin Drummond from Case Western Reserve University, representing a team also featuring doctors Adonis Hijaz and Shubham Gupta from UHA's Department of Urology. The team was selected for $25,000 in funding to help lift their prototype to the next level. Colin, congratulations to you and the team, and please tell us about your project.
Super, thank you very much. On behalf of Dr. Gupta and Adonis Hijaz and myself, I'm really pleased to be here today to share a novel concept that we believe will greatly facilitate pelvic floor disorder therapy. The issues associated with pelvic floor disorders have been around for quite a while, so you might think, well, aren't there solutions? And the answer is, yes, there are devices, but they actually don't meet the need. And if they did meet the need, then we wouldn't have issues of compliance. And we'll mention that in a few minutes. But let's go to the source of where the need comes from. It was through Dr. Gupta that he works with a lot of patients, and he provides care for quite a number of people. And he started thinking, well, my patients aren't getting the most benefit from the surgical procedures because it's just not a simple and effective means to provide dilation therapy. And so he started to think, well, gee, what's wrong here? I mean, there has to be a better way than what's in the market today. And of course, he, like most people, says, well, how difficult can this be anyway? And of course, the idea is that the need comes about from really two perspectives. First of all, if you think about this sort of disorder, this isn't, with deference to the prior presentation, this isn't like the Dollar Shaving Club. This isn't the kind of discussion you have at Christmas parties and things like this. It tends to be a very personal and private issue. And there's two situations here. The patients, the need for the innovation comes from two sources. One is the patients, and the patients face problems with the discomfort and the idea that it's uncomfortable. And really what happens is that, yeah, you can prescribe it, but they don't use it. And from a clinician perspective, after all of the work that's been done, it's disappointing that the compliance becomes a critical factor in success in subsequent therapy. So, those two perspectives are legitimate, and they actually drive some of the thinking. In addition to the fact that this is a very, very large market, it's a huge transgender population, hundreds of thousands of vaginal reconstruction issues, as well as roughly 2 million women with pelvic floor disorders, probably greater than that. So the need is clear, and the need is documented in the literature. And so now the question is, well, what do you do? So Dr. Gupta knows a fellow, a wonderful man, a surgeon by the name of Dr. Hijaz. And of course, I've had the privilege of working with Dr. Hijaz for about a decade. So the three of us got together and we said, gee, what can we do? What can we do to improve the situation? And so the idea is that, So the idea is that the system itself provides benefits. It provides benefits to the patient, and it provides benefits to the clinicians as well. The patients benefit because if you think about it, this is, vaginal dilation is something that, if you're considering at-home therapy, this is something that has to be simple, reliable, usable, easy, and that leads to compliance. And compliance leads to effective therapy. From the clinician perspective, the idea is that, once again, that when you have therapy, when you have compliance to therapy, then you have eventually success. So what we did was, we considered these benefits quite a bit, and we started to think about, what kind of innovation was required? What did we need to do? So we actually went ahead and put together a prototype, a very rough prototype, and this was a prototype strictly intended to define the technical specifications. It may be hard to believe, but the fact is there's no technical data out there that actually would help you design a device. So we went through the process of creating a preliminary prototype that would actually help us imagine what the next generation device would look like. So the plan actually has a few parts. Clearly, what we're going to do is we're going to, we have material sourcing that needs to be done. There's systems integration. There's a lot of technical things that need to be done to build on the knowledge we gained from the very, very rough, crude prototype. Also important is the team. We heard that in the prior presentation. And specifically, I recall the comment that our presenter made about the team, in which what Mark Twain said, the hazard is in what you think you know that ain't so. So you really figure out different perspectives, and you gain different perspectives by building out the team. And this requires a multidisciplinary team. So the critical project path for us is in expanding our team and building out a stronger prototype that can actually potentially be used for clinical trials. And we have some goals that we hope we'll reach in the next 6 months. So that's sort of a summary of the concept in general, and I thank you and welcome any questions.
Hey, thank you, Colin. We do have a couple questions if we still have a few moments. So one person's wondering about what's the pathway to get this technology to market so it can benefit patients fastest. They say it seems like a simple device that would be readily accepted.
Yeah, so the pathway to market. The pathway to market, I believe, in the spirit of the presentation we just heard, is, are you really addressing a patient need? And indeed, there are devices in the market, and I have this sort of simplistic view that if the devices actually solve the problem, then they would be sold and they would actually fill the need, but they don't. And of course, many people will try things and do things, but if it doesn't meet the need, then they discontinue it. And then, of course, then in the end, what's the value? But I think the key is to get the team together to have a multifaceted view of this and to really get the next generation prototype that says, are we really addressing the need? Are we really answering the question? Are we addressing the problem? So the critical path is really starts with saying, are we really addressing the need? We have some ideas technically, but we just have to expand on those and test them out.
Okay, great. So that kind of leads into another question that we just got. So, you're from Case, and we've got a couple urologists on the team, as well as the connection with others across the system. Yeah. So, as far as an interdisciplinary team combining, Case and UH, what makes it work so well?
That's an interesting question because. We are. It's really quite a diverse team, and even in things of the preparation of this presentation, we had different thoughts about what we might say and things like that. I remember I was working with an anesthesiologist 7-8 years ago, and one day, and we were doing some work on patient readmissions, and one day I said to Dr. Rowbottom, I said, I feel kind of bad. I really only understand about 20% of what you actually tell me. And he looked at me and he said, Colin, I actually only understand about 20% of what you say. So I think we're a good fit. So I think the idea is what really makes it work is that you're really upfront about what you do and don't know. Again, our previous speaker had the quote about Mark Twain, I think, which is very, very relevant. I think what you have to do is just be open and say, it's not about having an ego. It's just like putting that all to the side and saying, let's focus on the mission. Let's focus on the mission instead of us. And then the team gets together. And I think it's also about being able to expand the team and bring in other people and say, gee, what we really want to do is have the right competencies that complement each other to solve the problem.
Excellent.
Yeah.
Well said. Well said. Well, again, Colin and team, thank you so much. Congratulations, and we're looking forward to working with you soon on next steps.
Super. Thank you very much. I appreciate it.
Thank you. Okay, so next up we have Eva Johnson and Mary Alice Dombrowski, along with Lynn Wu from Pediatrics, on a combined team that had very similar submission ideas. The team has been selected for $25,000 in funding to help begin the earliest stages of concept development for their idea. Eva and Mary Alice, congratulations to you and Lynn. Please tell us about your submission.
Thanks, Ryan. Good afternoon, and thanks for having us. We're so excited to be here. I'm Eva Johnson, and I'm a general pediatrician at Rainbow. And I'm here today with Mary Alice Dombrowski, who is a nurse practitioner in the pediatric GI division. And we also work with Dr. Lynn Wu, who is a pediatric urologist, but is in clinic today and is unable to join us. We're calling our innovation Therapy to Go, as it is a home biofeedback program for treating pediatric voiding dysfunction and constipation. While I work in general pediatrics and see many children with voiding and stooling issues, my inspiration for this innovation actually came from my experience as being a parent. My youngest child was always a wetter. He always came home from school with wet pants. And in kindergarten, it became very frustrating for both of us to go through this daily wetting. And so we saw a pediatric urologist at Rainbow who diagnosed him with dysfunctional voiding and recommended biofeedback therapy. Every 6 to 8 weeks, weekly, we drive 40 minutes to the west side to the pediatric urology office for treatment. In the office, my son was hooked up to a machine like the one seen here and was taught to relax his pelvic floor muscles while contracting his abdominal muscles, which he practiced by watching the screen in the office to judge his technique. After each session, they would tell us, go home and practice this daily. My 5-year-old had ADHD and was not a very good listener, and saying go home and practice this was a challenge. I didn't know if he was contracting and relaxing the right muscle groups, and it was hard to know whether he was really even practicing at all. I remember telling the urologist at the time that he should go home, that he should make this into a home therapy and retire early, and he sort of smiled and shrugged and walked away, and since then it's always been on my mind. It's been 7 years later. My child is hardly alone in his struggle with dysfunctional voiding. At age 7, 6% of girls and 4% of boys have daytime wetting, and 40% of pediatric urology office visits are for dysfunctional voiding. The annual healthcare costs for dysfunctional voiding across all ages, that's children and adults, is in the tens of billions of dollars. Childhood chronic constipation has even higher prevalence rates. Between 3 and 5% of children have chronic constipation, and constipation accounts for 3 to 5% of all primary care pediatric office visits. A recent study estimated that healthcare spending for pediatric chronic constipation at $3.9 billion annually, and this does not account for the expenses that families have out of pocket and does not monetize the emotional distress and decreased quality of life associated with pediatric constipation and dysfunctional voiding. And I'm going to turn it over to Mary Alice.
We know that pelvic floor biofeedback therapy works for many children with bowel and bladder dysfunction. As Eva mentioned, currently we ask children to attend 4 to 6 sessions, with each session lasting about 30 to 60 minutes and sometimes more. During these visits, healthcare providers provide coaching to help children learn how their muscle groups work. Visual feedback is provided so that they may benefit from knowing what they can and can't do and what they're doing correctly and incorrectly. To be most effective, we ask that parents and caregivers and children come for a session every 1 to 2 weeks, and we expect them to practice daily in between sessions. Unfortunately, patient and provider barriers exist that prevent this type of therapy from happening. Patients and family members must miss work and school in order to attend these long appointments. And transportation issues, the geographic locations of our offices can make access a big concern. Oftentimes, insurance coverage is variable, and there are sometimes high out-of-pocket costs that many patients just can't afford. Furthermore, many parents and patients don't know if they're doing the exercises correctly, or they can't remember what they were even supposed to do. And some kids just don't want to do them, and others forget. Providers have their own set of challenges with biofeedback programs in the office. It is often difficult to find open slots to accommodate all these appointments. Reimbursement can be low. Poor compliance on the part of the patient can lead to frustrating visits, and everybody is discouraged and sometimes want to just give up. We know that if we could help these children engage in this therapy, that it might provide a lot of benefit. But how do we do that? Therapy to go. Therapy to go will minimize these issues, and it will protect valuable time and resources. Therapy to go could be a standard therapy in all bowel and bladder dysfunction clinics, even around the world. We even can imagine therapy to go being useful outside of the healthcare setting. Wouldn't it be great if we could make potty training more fun? We know parents want less medication and more treatment options. And we know that children love to play video games. This innovation offers both. There is currently no pediatric program like this that we can offer our patients with bowel and bladder dysfunction, at least not yet.
So now that we have our innovation, how do we move forward? We'll be developing and testing a home-based biofeedback program that a child would use to practice therapy at home. Once we have the prototype, we will pilot with a small group of patients at Rainbow. We already have pediatric GI and pediatric urology as part of our team, and we will need to engage with engineering and software design to help develop the prototype. Our success will be measured by the feedback we get from patients and families about their compliance and satisfaction with the system, and by outcomes judging improvement of dysfunctional voiding and constipation symptoms. I want to thank you for your time, and thanks to the Innovation Office for seeing the potential in this idea. And we're happy to take any questions.
Okay, thank you, Ava. Thank you, Mary Alice. We do have a few questions if we've got some time. So someone sent in, what age range could use this device? And they're curious, could it be used for adults as well?
Absolutely. We're currently using in children 3 and older, but this up to age 26 in our clinics, but certainly it could be used for any age. And for many adults who have these same issues, as mentioned in previous talks, we could use a video game format for bowel and bladder dysfunction across the board.
Okay, great. So another one that came in was someone's asking about what's the difference between how this would be used for urinary dysfunction versus bowel dysfunction?
Well, it's used very similarly for both bowel and bladder. The same muscle groups are used in the abdomen and in the anal area for pelvic floor control. One difference might be if individuals are practicing the actual act of defecation or urination. And in these situations, we would use, again, the video game format so that individuals would know they're doing it correctly or not.
Okay, great. So one more. What would be the cost to the patient or the family? Is there a reimbursement pathway for this now or potentially in the future?
We'd hope there'd be a reimbursement. The cost, as you can hear, is in billions of dollars that we currently spend in healthcare costs for constipation and dysfunctional voiding. So we know that there's a lot of already money that's spent on it. So we can imagine if we could make it more effective treatment at home, that we can imagine insurance companies would find this appealing, and because it could decrease costs in the long run.
Okay. Well, great. Thank you again so much, Ava, Mary Alice, and to Dr. Wu at home. Congratulations, and we're looking forward to working with you on this project.
Thank you.
Thanks.
Okay, so rounding out our top three, and here to present for the team is Ryan Yuza, who's also representing several others. So we've got Jeff Marks, Amitabh Chak, Steve Shomish, and Daniel Hashimoto from UH's General Surgery Group on the team as well. The team was selected for $15,000 in funding to help develop and prototype their device concept. Ryan, congratulations to you and the team, and please tell us more about your idea.
Ryan, thank you very much. As Ryan said, I'm also Ryan Yuza. I'm an assistant professor of surgery in the Department of General Surgery. I'm going to tell you about our device here. So, robotic surgery has been a major force in the surgery world because of the improved dexterity, visualization, and functionality of the robotic platform. And this is particularly true in robotic hernia surgery, where roughly 500,000 cases are performed in the US every year. One of the challenges in hernia surgery is that when operating at extreme angles or in small spaces, the port has a tendency to retract back into the abdominal wall. This video is showing one of my cases here. And just for size reference, those instruments that you see on the screen are about a centimeter in length from the tip. This is 10x magnification, so we're working in a very small space, okay? This is my life. As the director of hernia surgery at University Hospitals Cleveland, I treat hundreds of patients and their hernias every year. These range from routine inguinals to complex abdominal wall reconstructions, where I spend hours meticulously separating the layers of the abdominal wall. And during these cases, I'm constantly frustrated with those ports that you see coming through the abdominal wall, moving around, retracting back in. I'm trying to maintain a large, clean working space to perform my operation, and I frequently have the tissues collapsing around my port, blood dripping down on my camera, and just get frustrated with it sliding back. From that experience, I designed a device that would fix my problems. It would improve visualization, increase working space, all while preventing the port from retracting back into the abdominal wall. So during robotic surgery, dislodgement of the metal trocar is a common nuisance factor and a potential avenue for patient injury. Some of the issues that the patients face are that this sliding around, it can cause gas to translocate into the subcutaneous spaces, it can damage a patient's skin and other tissues, and it can prolong OR times. From a clinician standpoint, this loss of visualization and loss of the operative field leads to prolonged OR times, increased complications, and worse outcomes for the patient. So the overall market opportunity in this case, the global robotic surgery market is about $5.5 billion in 2020, and that's anticipated to grow about 10 to 17% per year. That translates into roughly 500,000 robotic surgeries, and with 3 to 6 ports per case, that translates roughly into 1.5 to 3 million devices per case. So what is this design? This is a sleeve, an internal sleeve with a retention flange that fits through the existing ports to prevent that retraction and dislodgement. That'll lead to reduced risk of tissue damage and subcutaneous insufflation during the operation. It'll also lead to improved visualization and working space for the surgeon, which will improve outcomes and OR efficiency. Current devices on the market, there are a few, but what they do is they require upsizing of that port to accommodate the robotic port through it. Okay, so this is a secondary port that you then nest the robotic port in. The problem with that is it requires a larger incision, which has its own complications of bleeding, risk of infection, increased incisional hernia rates. It also is expensive to open another port just to place this port through. So by having an internal retention sleeve, we can optimize that port insertion by avoid that aforementioned risk of tissue trauma. So our plan, we've already performed a preliminary market analysis as we've discussed here. We're going to take this on to prototyping and in situ testing. We have a team, a multidisciplinary team of inventors with this, from GI to surgery to biomedical engineering, with a history of innovation and design. And we'll work with the STAR lab at Case Western to further develop these prototypes through iterative processing to come up with the optimal design for our ports. Our goal is to identify the ideal candidates for this design, and ultimately reduce trocar site dislodgements and trauma associated with that. So I appreciate your time and the ability to present our design. I'm happy to answer any questions from the other Ryan.
Thank you, Ryan. We do have, I think, 3 questions. So the first one, someone's wondering what makes this problem unique to robotic ports and why not all laparoscopic ports?
That's a great question. So with robotic surgery, the way the robot controls the instrument is by external fixation of the port and then the instrument going through it. The issue with external fixation without internal fixation is that as that port is moving through the laminar layers of the abdominal wall, it can actually slide back or dislodge into the tissues. As you're bringing instruments in and out, you can then go through the tissues if you're not careful, or the gas, as you're insufflating to blow up the abdominal wall to create working space, can actually dissect through the patient's tissues. Conversely, with laparoscopic ports, there is no external fixation. The external fixation is actually the abdominal wall. And so bringing ports in and out, they maintain their position in the abdominal wall as you're doing that.
Okay, great. So the next question's more into the nitty-gritty med device stuff. Would you anticipate this being a disposable or reusable part?
We would see this as the disposable. The current devices are industry specific, metal cannula that can be easily processed. Our device is an internal sleeve that fits within the current port. You would use it with each individual one. At the end of the case, you could throw it out. We're looking for simple, quick, and effective, and I think we can accomplish all 3 of those with a disposable product.
Okay. And lastly, this one comes directly from me. So I appreciate the market research. That's a lot of what I do at UH Ventures. So my question is, have others within your field also echoed a need or identified the problem? And have you done some of that initial, hey, if you had something that could do this, would you be willing to use it?
Yeah, that's a great question. So yeah, we have multiple forums online where we toss ideas off of each other. We review videos for each other's of these types of surgeries. And consistently we see the same issues. And in talking to close colleagues of mine, we all express the same frustration of trying to maximize our working space and avoiding the traumas that occur when the port is moved within the abdominal wall. So yes, I've got several folks who will agree to buy this once we get to that stage.
Great,
Yep.
Great. That's very promising. Well, again, Dr. Yuza, thank you very much. Congratulations to you and the team, and we're excited to kick off the project.
Thank you.
Hopefully soon.
Yep.
All right.